So, pre-op evaluation of the morbidly obese patient is really the most important thing that you can do for these patients. So, pre-op airway assessment in this patient population is the most important of the important things. So, in an analysis of the closed claim malpractice claims in the US related to airway management, obesity was the most significant role in the majority of cases. Anatomic changes associated with obesity that contribute to potential difficult airway include limited movements of the atlantoaxial joint and cervical spine by upper thoracic and lower cervical fat pads, excessive tissue folds in the mouth and in the pharynx, short, thick neck, a thick submental fat pad, suprasternal, presternal, and posterior cervical fat, and large breasts in females and in males sometimes. Excessive pharyngeal tissue deposited in the lateral pharyngeal walls may not be noticed during routine airway exam. The history obtained from the patient and examination of the prior record may help predict this kind of difficult airways. Obesity is an accepted risk factor for difficult mask ventilation and airway management. With adequate positioning and airway resources available, most of these patients can be adequately and safely managed. Overall, the degree of BMI by itself doesn't seem to have much influence on difficulty of laryngoscopy. So, obesity is not an independent predictor of difficult intubation, but definitely for airway management, specifically mask ventilation. So, such difficulties in most studies correlate with increased age, male sex, TMJ pathology, Mount Putty of 3 and 4, sleep apnea, and abnormal upper teeth. The probability of a problematic intubation is about 5% when the neck circumference is 40 centimeters or more, and it increases to 35% when the neck circumference is 60 centimeters. So, if you have a guy, you can ask him what size collar do you wear on your shirt. That's very important. Because obese patients often have limited exercise tolerance and may appear asymptomatic because they don't move, you gotta assume that they have significant cardiovascular disease. These patients should be evaluated for systemic hypertension, pulmonary hypertension, signs of right or left ventricular failure, and ischemic heart disease. Signs of heart failure like, elevated jugular venous pressure, pathologic heart sounds, pulmonary crackers, hepatomegaly, and peripheral edema may all be even more difficult to detect because of the excessive fat. Pulmonary hypertension is fairly common in this patient population because of the chronic pulmonary impairment. The common features of the pulmonary hypertension are exertional dyspnea, fatigue, and syncope, which reflect an inability to increase the cardiac output during activity. Tricuspid regurgitation on echo is the most useful confirmatory test of pulmonary hypertension, but should be combined with the other clinical evaluation. If you have an ECG, it can show signs of right ventricular hypertrophy like tall precordial R waves, right axis deviation, and right ventricular strain. The higher the pulmonary artery pressure, the more sensitive the ECG. Chest x-rays may show evidence of underlying lung disease and prominent pulmonary arteries. Evidence of sleep apnea and obstructive hypoventilation syndrome should be obtained pre-op, not only because patients with these symptoms may be difficult airway management, but also because the conditions are associated with increased periop pulmonary complications. A history of hypertension or a neck circumference of more than 40 centimeters correlates with increased probability of sleep apnea. And really, OSA is a legitimate reason to delay surgery for proper workup. OSA patients should generally be treated as inpatients, but outpatient surgery can be considered under certain circumstances. Like if the patient has mild sleep apnea, we can use local or regional anesthesia with minimal to no sedation. and availability of a 33-hour post-op observation unit in the PACU, and when the patient can resume oral medication at the time of discharge. OSA patients on CPAP at home should be instructed to bring their CPAP with them. And if they forget, their companion can go bring it while the patient's having surgery. The possibility of invasive monitoring, prolonged intubation, and post-op mechanical ventilation should be discussed with every obese patient. This is so important. The ABG measurements help evaluate ventilation as well as the need for periop oxygen administration and post-op ventilation. Routine pulmonary function tests and liver function tests are not cost-effective in asymptomatic obese patients, so we just don't do it unless there's a reason to, like everything else. Patients that are scheduled for repeat bariatric surgery should be screened pre-op for long-term metabolic and nutritional abnormalities. The high prevalence of insulin resistance and diabetes in obese patients justifies the need for considering glucose checks pre-op and putting them on insulin infusion if needed. Pre-op eval should include assessment of therapies for glycemic control, last time and dose of pre-op administration, and usual glucose value for specific patients. Lights should be checked before surgery, particularly in patients with poor compliance to medication or people that are acutely ill. Elevated LFTs, mostly ALT, are seen in many obese patients, but there's no correlation between the abnormalities of routine liver function tests and the capacity of liver to metabolize drugs. Dexmedetomidine is an exception here, though. Other nutritional deficiency like B12, iron, calcium, and folates can definitely be present. And these vitamin and nutritional deficiency can lead to a collective form of post-op polyneuropathy known as acute post-gastric reduction surgery neuropathy, or APGARS neuropathy. And it's a polynutritional multisystem disorder characterized by protracted post-op vomiting, hyporeflexia, and muscular weakness. Differential diagnosis of these disorders include thiamine deficiency, like Wernicke encephalopathy or beriberi, vitamin B12 deficiency, and Guillain-Barré syndrome. And close attention to dosing and monitoring of neuromuscular blockade is recommended in cases of suspected or diagnostic APGARS neuropathy. Chronic vitamin K deficiency may lead to coagulation abnormalities requiring administration of vitamin K analogs or FFP. Morbid obesity is a known risk factor for peri-op thromboembolic events like sudden death or acute PE. Several thromboprophylaxis protocols exist and are being developed in peri-op evaluation, and peri-op should include consideration for these plans. Guidelines from the American Society of Chest Physicians recommends that patients undergoing any bariatric surgery, the combination of the SCDs with a single shot of heparin, and warning the greater doses in patients may be needed in the non-obese ones. A prolonged post-op thromboembolic prophylactic regimen for 1 to 3 weeks may even be needed. For risk factors for the development of DVT are particularly significant, like venous stasis disease, BMI of more than 60, central obesity, and OHS and or OSA if present. So if present, pre-op prophylactic placement of an IVC filter may even be considered. Combination of short duration of surgery, lower extremity pneumatic compressions, the SCDs, and routine early ambulation may preclude mandatory heparin anticoagulation, except in patients with a history of previous DVT, non-hypercoagular state, or significant family history of DVT. So, general principles for pre-op evaluation: assess the prior record, look at anesthetic problems, difficulty of rate management or IV access, and if they were admitted to ICU for any reason. And also, your evaluation should include cardiovascular and respiratory system, look at the hypertension, heart failure, arrhythmia, obesity-related hypoventilation syndrome, and any metabolic disorders like diabetes or hypothyroidism. A patient interview will look at clinical signs suggested for cardiac and respiratory pathology, and do your clinical exam, you do your instrumental exam, ECG, echo, and coronary angiography if needed. And sleep study can become very significant because when you do your sleep study, you get this AHI score, the apnea hypopnea index, and if it's more than 30, it's the predictor for rapid desaturation on induction. So that should make your spidey senses go